Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident at the University of Pittsburgh, and today's topic is breast cancer. Breast cancer is the most common malignancy in women in the United States, other than non-melanoma skin cancer. Women have a 1 in 8 lifetime risk of developing breast cancer. It's also the second most common cause of cancer death in women, with the first cause of death being lung cancer. Breast cancer is classified based on hormone expression, so estrogen and progesterone receptor positivity, as well as expression of the HER2 oncogene. The majority of breast cancers, over 70%, are hormone positive and HER2 negative. A small subset of breast cancers, around 13%, are triple negative. About 10% are triple positive, and it's very uncommon for breast cancer to be hormone negative but HER2 positive. In the first part of breast cancer overview, we'll try to get through presentation and workup, imaging, pathology, as well as staging. We'll save the treatment overview for part 2 just because it's a lot to get through. Let's start with presentation and workup of breast cancer. 90% of the time, breast cancer is actually detected on a screening mammogram. Now, who should get a screening mammogram? Different cancer societies will have different recommendations for screening mammogram. The American Cancer Society, for instance, recommends an option to start screening at the ages of 40 to 44, with annual screening mammogram recommended for women 45 to 54, and biennial screening mammogram for women ages 55 and above. The USPSTF recommends a biennial screening mammogram for all women between the ages of 40 to 74, and no screening recommended after the age of 75. This is for average risk women. Keep in mind that high risk women should always have annual screening, and the American Cancer Society actually recommends getting an MRI for these women as well. So what qualifies as a high risk woman? Anyone who is a BRCA mutation carrier or is an untested first-degree relative of someone with a BRCA mutation, they should start either at age 25 to 30 or 10 years before the youngest first-degree relative was diagnosed. If they have a history of mantle or thoracic radiation between the ages of 10 to 30 years, they should start with screening imaging either 8 years after their treatment was completed or at age 25, whichever is later. And also women that have had biopsy-proven lobular neoplasia, atypical ductal hyperplasia, or a personal history of breast cancer. They should begin whenever they were diagnosed. So, like I said, most of the time women are going to be diagnosed based on a screening mammogram. 10% of the time, however, breast cancer might be detected either via self-exam or a clinical breast exam. Typically, it's going to be a painless mass, although sometimes it can present with pain. Nipple discharge is usually an indication of a benign etiology, but this may happen in breast cancer. Women may also have nipple retraction or axillary lymphadenopathy with occult primary. It's also important to realize that breast cancer does not just affect women, it can also affect men in a small percentage of cases. In terms of a differential diagnosis for a breast mass, you can think about fibroadenoma, cysts, infection, thrombophlebitis, which you'll hear the word Mondor's cord for thrombophlebitis, intraductal papilloma, which often presents with bloody nipple discharge, sclerosing adenosis, or a lactocele. So it's important to keep in mind other causes that may contribute to a breast mass or breast pain or even nipple discharge. Now, what are some risk factors for breast cancer? Estrogen exposure is certainly a huge risk factor, and there are a host of different things that can lead to increased estrogen. So hormone replacement therapy is certainly an important one, but nulliparity or older age at first birth, lack of breastfeeding, late menopause, things that increase your estrogen. If people have family history of breast cancer, and there are a few different genetic predisposition syndromes that are listed here, so BRCA1 and 2 mutation, Li-Fraumeni, Cowden syndrome, ataxia telangiectasia, and Peutz-Jeghers syndrome can all lead to a genetic predisposition with an increased risk of breast cancer. Anyone that has a personal history of breast cancer, so either a prior history of breast cancer, carcinoma in situ, or even just atypical ductal hyperplasia and dense breast tissue. If people have had radiation during their youth, that can certainly increase your risk of breast cancer. And then finally, there are some lifestyle and exposure influences as well. So high-fat diet, postmenopausal obesity, and sedentary lifestyle can increase your risk of breast cancer. So when you're examining a patient, whether it's just a screening exam, whether they came in with an imaging abnormality, or whether they actually came in with some palpable abnormality, it's really important to understand the breast anatomy so that you know how to communicate what the abnormality is to your colleagues and in your exam. So the breast is divided into 4 different quadrants: the upper quadrant, lower quadrant, inner quadrant, and outer quadrant. So we have upper outer, upper inner, lower outer, and lower inner quadrant. The upper outer quadrant is the most likely location for cancer to be located. And if you think about it, it makes sense. The upper outer quadrant occupies the most volume, so it's most likely that cancer would be there. The lower inner quadrant, on the other hand, is the least common location for cancer. The other way that we note where the cancer is located is by the o'clock position of the tumor. So think about it as a clock superimposed on the breast in anatomical position. So if you think about it that way, 3 o'clock on the right breast will actually be on the inner side, but 3 o'clock on the left breast will actually be on the outer side of the breast. So we can certainly locate based on the o'clock position, and then using imaging, or if you're just going off your clinical exam and you can palpate it, you can also think about how far away from the nipple is it. So oftentimes you'll see breast cancer located as 2 o'clock on the left breast, approximately 4 centimeters from the nipple. The other piece to keep in mind in terms of anatomy of the breast is the lymphatic drainage. So the lymph node regions that are at risk for regional involvement. So in general, when we think about the regional lymph nodes for the breast, there are 3 different areas that come to mind. So that includes the axillary lymph nodes, the supraclavicular lymph nodes, and then the internal mammary lymph nodes. Most commonly, breast cancer is going to be draining to the axilla. And axilla is divided into 3 levels based on their relationship to the pec minor muscles. So axillary level 1 are lateral to the pec minor, axillary level 2 are posterior to the pec minor and also in the space between the pec major and the pec minor, known as Rotter's nodes. And axillary level 3 lymph nodes are medial to the pec minor. The supraclavicular lymph nodes are located from the bottom of the clavicular head to the cricoid, and these, when cancer has spread to the supraclavicular lymph node, it's much more locally advanced. It's technically not yet stage 4 metastatic, but when it's spread to the supraclavicular lymph nodes, that means that the cancer is very advanced and has spread very far. The internal mammary lymph nodes are located in the first 3 intercostal spaces lateral to the sternum, and these are not very commonly involved, but if a tumor is located medially, especially in the lower inner quadrant, in that case, the internal mammary lymph nodes may be involved. So with that understanding of breast anatomy and lymphatic drainage, that brings us to the workup of a patient with breast cancer. So anytime you have any patient presented to you on board exams, the very first thing to do is start with a full history and physical. And in this case, we're going to focus on a bilateral clinical breast exam and a lymph node exam, examining their axilla and their supraclavicular lymph nodes. In terms of imaging, and we will break down the different types of imaging, but typically all patients will get some kind of mammogram, whether it's a screening mammogram or a diagnostic mammogram. And in addition to that, they may or may not need either an ultrasound or an MRI. We also definitely need to have a pathological diagnosis of cancer. And for this, we typically recommend a core biopsy rather than a needle aspiration, because with a needle aspiration, we can't differentiate between ductal carcinoma in situ and an invasive ductal cancer. So really, we need a core biopsy to diagnose invasive ductal carcinoma. And if the patient has a high enough clinical stage, so if they have clinical stage T3A or higher, meaning that they're T3N1, T4, or N2, then we need systemic staging. And we will talk in great detail about what these stages mean and what T3N1 versus T4 or N2, all of that means. But just keep in mind that if the tumor size is large enough, or if they have lymph node involvement, then we need systemic staging to make sure that they don't have metastatic disease. So what does that systemic staging entail? That could be a CT, chest, abdomen, pelvis, either a bone scan or a PET scan. You might consider a brain MRI. And this is something more for medical oncology, but if you're considering administering anthracycline-based chemotherapy, it's also important to get an echocardiogram to establish their baseline cardiac function. So we just talked about a lot of different aspects of workup, and there's a lot to digest there. So let's start by breaking it down. First, let's talk about breast imaging. As we've said, the staple imaging modality for breast cancer is mammography, which is basically an X-ray of the breasts. And the way that a mammography works is it is a breast placed on a flat support plate and then compressed with a parallel plate called a paddle, and then low-dose X-rays pass through the breast to a detector that's located on the opposite side. The photographic film plate is a detector that captures the X-ray image on film, and then a solid-state detector can be used to transmit electronic signals to a computer and actually form a digital image. So the bottom line is a mammogram is basically an X-ray of the breast, and it can be kind of uncomfortable for patients because their breast has to be compressed against a flat support plate using that paddle, and so oftentimes it's not a comfortable experience. But we basically flatten the breast, get an X-ray, and then typically we use a solid-state detector to transmit that image to a digital image. One thing that I did not understand as a resident when I first started residency is the difference between a screening mammogram and a diagnostic mammogram. So I'm going to try to explain what the difference is here. A screening mammogram is obtained in patients that are asymptomatic. So we are just screening and just looking to see if there's any abnormality. When we obtain a screening mammogram, we typically just get two views. So those views are a craniocaudal view and then a mediolateral view. In the craniocaudal view, we're pressing the breast craniocaudally. So imagine something pressing down on the breast. And when we press down on the breast through the craniocaudal view, that then allows us to visualize the outer versus the inner quadrants of the breast. So craniocaudal, you can tell outer versus inner. When we do the mediolateral oblique view, what we're really looking at is compressing the breast sideways. And then at this point, we're dividing the breast into now the upper and the lower quadrants. So when we combine these two different projections, the mediolateral oblique and the craniocaudal, we can get some info on the quadrant in which any abnormality might be located. So outer versus inner using the craniocaudal, and upper versus lower using the mediolateral oblique. The screening mammograms are typically performed by a technician, and screening centers don't necessitate having a physician on site. A diagnostic mammogram, on the other hand, is performed with a radiologist on the site, and the radiologist is actually present and very involved in the procedure. So the difference between a screening and a diagnostic mammogram is that a diagnostic mammogram is obtained in symptomatic patients. So either they have a palpable mass or they presented with an abnormal finding on their screening mammogram. And so we know that there's something abnormal there, and we're trying to actually obtain additional views to further assess these abnormalities. Some of the different things that they can do on a diagnostic mammogram include spot compression and magnification views. So magnification views, you can kind of zoom in and better evaluate any calcifications or things like that. With spot compression, they actually will use a smaller paddle and press on the area of investigation, and it actually allows them to differentiate suspicious mass versus just dense breast tissue. So if there's something there and we're not sure if it's dense breast tissue or an actual mass, we can do spot compression to that area with the idea that if it's dense breast tissue, it'll kind of melt away and it'll reveal itself as dense breast tissue. But if that mass remains there and suspicious and prominent, then we're more concerned that it's an actual mass. Here is just a representative example of MLO and craniocaudal views on a screening mammogram. Based on the mediolateral view, you can tell that it's in the left breast in the upper quadrant. And then on the craniocaudal view of the left breast, you can tell that it's in the outer quadrant. So this is an example of a 10 millimeter spiculated mass located in the left upper outer quadrant. Based on the appearance on a mammogram, the radiologist will assign a score called the BI-RADS score. BI-RADS stands for Breast Imaging Reporting and Data System, and you'll learn that based on the different disease sites, there are different scoring systems. So for breast, there's BI-RADS, for liver, there's LI-RADS, and so on. So the BI-RADS scores are shown here, but essentially, I think what's important to note here is that 0 is incomplete, 1, 2, and 3 are either negative, benign, or probably benign. And then 4, 5, and 6 is where you start thinking about a biopsy. So 6 is the highest and it's biopsy proven. So we have already confirmed that there is a malignancy there. 5 is highly suggestive of of malignancy, and so a biopsy is required. And 4 is where you're suspicious for malignancy and are considering a biopsy. So 4, 5, and 6 in my book are the ones that are really concerning for malignancy. 6 we know 100% is biopsy proven malignancy, and 4 and 5 is where you either consider or require a biopsy. Besides mammogram, there's a couple of other imaging modalities that you should be familiar with for breast cancer, and the first of these is an ultrasound. So a breast ultrasound is typically not routinely utilized for breast cancer screening, although it may have a role in screening women with dense breast tissue, especially younger women. Less than 30 years old tend to have more dense breast tissue, so sometimes an ultrasound is more insightful than a mammogram. However, we do utilize an axillary ultrasound sometimes to clarify abnormalities that we see on mammography, and also to clinically evaluate for suspicious lymph nodes. So oftentimes breast patients will get an axillary ultrasound just to look for any suspicious lymph nodes. And then the last form of imaging that we should talk about is a breast MRI. So when you hear about breast MRI, a dynamic contrast enhanced MRI, oftentimes a multi-parametric MRI, is what is used. And this can give deeper information about the morphology of a lesion. MRIs tend to have high sensitivity but moderate specificity, so a higher rate of false positives. And so that's why we use multi-parametric imaging. Features on MRI that tend to be suspicious for malignancy. So any kind of mass-like enhancement, often if they have spiculated margins or an irregular shape, or even non-mass-like but calcifications can be suspicious for malignancy. MRI is often used for staging and evaluation of response to neoadjuvant chemotherapy. It also allows us to see and stage the axilla as well and assess the response. Who will get a breast MRI? I've actually found that this might be institution dependent. Some institutions will pretty much get a breast MRI for everyone, and some people are more selective if they have a clinical suspicion for axillary nodal involvement or something like that, or if they know that they're going to be getting neoadjuvant chemotherapy. But, depending on the institution, just keep in mind that practices may vary. So we talked deeply about the imaging for breast cancer. Let's switch gears a little bit now and talk about pathology. Typically what happens is that a patient presents with an abnormality on screening mammogram. That then prompts further workup with a diagnostic mammogram, and then we need to get a biopsy. And we already talked about this before, but a core needle biopsy is the preferred method because it's the least invasive and it's the way of sampling enough tissue to make a diagnosis. Alternatives include a fine needle aspiration or an excisional biopsy. The FNA is often insufficient because we just get kind of a sample of cells, and it doesn't help us to differentiate between an invasive ductal carcinoma or a ductal carcinoma in situ, and we end up needing a core biopsy regardless. An excisional biopsy is sometimes mandated if a core needle is not feasible or if it's indeterminate, but that involves actually surgically removing the entire lesion. So core needle biopsy is the least invasive upfront modality to get enough tissue to make a diagnosis upfront. Whenever the biopsy is done, clips can actually be placed at the time of biopsy to mark where the tissue was sampled. And these are helpful for surgeons to intraoperatively locate the clips to confirm whether or not the correct area was removed. And if there's a benign finding, these are also helpful to future radiologists to kind of mark sites that have previously been biopsied. There's a few different biopsy techniques, meaning when I say techniques, I mean what kind of imaging we use to help guide the biopsy. So what we prefer to do is just get an ultrasound guided biopsy. And often this is used for masses that are palpable, and it's the preferred modality if the image is, if the lesion is visible on an ultrasound, because it's probably the easiest to schedule an ultrasound guided biopsy. And if there's any abnormal axillary lymph nodes that are seen, those can be biopsied via ultrasound guided biopsy as well. If there's a non-palpable lesion and there's suspicious calcifications, then sometimes a stereotactic biopsy or needle localization is needed. An MRI-guided biopsy would be indicated if it's only visible on MRI. And then the punch biopsy might be considered if there's something like Paget's disease or suspicious dermal involvement, if you're suspecting something like inflammatory breast cancer. But I would say most commonly what we see is just an ultrasound-guided biopsy, or we may see stereotactic biopsy or MRI-guided biopsy if it's not visible on ultrasound. When we finally get the pathology result, when it comes back in the report, what we're looking for is, number one, to verify whether or not this is cancer, and number two, if it is cancer, what kind of cancer is it? So 80% of the time, if it's cancer, it's going to be an invasive ductal carcinoma. That means that it's a carcinoma that arose from the ducts within the breast. I think this diagram does a nice job of showing what a normal duct looks like versus ductal hyperplasia. Then you can get atypical hyperplasia if those cells start to look abnormal. And ductal carcinoma in situ is a cancer, but it's considered T0, so stage T0, because it has not yet broken through that basement membrane. Once it breaks through the basement membrane and starts invading, that's when it's considered an invasive ductal carcinoma. So 80% of the time, that is where breast cancers arise from, is the ducts of the breast. Less commonly, say 5 to 10% of the time, invasive breast cancer may arise from the lobules of the breast. Remember, the breast is just all made up of ducts and lobules. So 5 to 10% of the time, you might get what's called an invasive lobular carcinoma. And it doesn't really affect treatment management if it's an invasive lobular carcinoma. You still treat it the way that you would treat an invasive ductal carcinoma, but just something to keep in mind that it can come from two different places. The distinction between invasive ductal carcinoma and invasive lobular carcinoma is probably less important than the distinction between a ductal carcinoma in situ versus a lobular carcinoma in situ. So remember, we showed that diagram and basically showed that a carcinoma in situ is carcinoma that has not yet broken through that basement membrane and it has not become invasive. So for ductal carcinoma in situ, ductal carcinoma in situ is considered a stage 0 breast cancer, and we stage it as PTIS, so that means carcinoma in situ. I might have misspoken earlier and said T0. It's a PTIS, so carcinoma in situ, considered a stage 0 breast cancer. It's less common than invasive ductal carcinoma, but if we do treat it with breast-conserving surgery, so that means like a lumpectomy, we typically say that for DCIS, we recommend adjuvant radiation in most of the cases. And the reason is because after you resect a ductal carcinoma in situ, there can still be up to a 30% risk of recurrence. So half the time, if it were to recur, it might not, it just recurs as a ductal carcinoma in situ, so not a true invasive cancer. However, half the time when it does come back, it comes back as an invasive carcinoma. And so that's kind of the rationale for offering adjuvant radiation after breast conserving surgery for ductal carcinoma in situ. In a later talk, we'll go through some of the data for DCIS and talk about cases where we may consider omitting that. But most of the time, if treated with breast-conserving surgery for DCIS, we recommend adjuvant radiation because, like I said, it can be up to a 30% risk of recurrence. And if it does come back, then half the time it comes back as an invasive carcinoma. So it's really the radiation to reduce the risk of it coming back as an invasive carcinoma. The other type of carcinoma in situ is lobular carcinoma in situ, and this is not considered a malignancy. The exception to this rule is something called pleomorphic LCIS, which is thought to behave like a high-grade DCIS, and so we end up treating it as if it were a high-grade DCIS. But LCIS otherwise is considered an independent risk factor for developing cancer, but it's not considered a malignancy, and it's not something that we treat. Now, other than the ductal carcinoma and invasive lobular carcinoma, there are a few more rare types of breast cancer that we sometimes see. So these include tubular, medullary, mucinous or colloid, papillary, and cribriform. In order to be described as a primary kind of tubular breast cancer, or whichever one of these subtypes, you need at least 90% to make up the predominant pattern. And these different subtypes of breast cancer have kind of different associations. So for example, cribriform tends to be hormone positive. The mucinous and papillary tend to affect older patients. Medullary is associated with BRCA1, younger age at diagnosis, so less than 50 years old, and more of these patients tend to be triple negative. So they have different kind of risk factors associated with them. I think the key takeaway is that the most common type of breast cancer is usually invasive mammary carcinoma, not otherwise specified, and this is a pure invasive ductal carcinoma. So once we find out on the pathology report whether it is a breast cancer and what kind of breast cancer it is, probably the next most important thing is to identify whether it's hormone positive and HER2 positive. And another number that comes with that is something called the Ki-67, which is a proliferation index. So the higher the Ki-67, it kind of indicates that these cells are more progressive, more likely to be dividing. One of the most commonly accepted ways of kind of dividing breast cancer into different molecular subtypes is a system of classification that was actually defined in the early 2000s based on gene expression profile studies. So in this study, they looked at a few different things. So they looked at the hormone receptor positivity, they looked at HER2 new positivity, and then finally they looked at Ki-67, which we said is the proliferation index. And based on these three different factors, they kind of divided breast cancer into four different molecular subtypes. So these are luminal A, luminal B, HER2 enriched, and basal-like. Luminal A is probably the most favorable type of breast cancer because it's hormone positive, HER2 negative, and the Ki-67 is less than 14%. So they're not as proliferative, they're hormone positive, HER2 negative. And these are also probably the most common type of breast cancers, occurring about 70% of the time. Then we get into other subtypes, including luminal B, HER2 enriched, and basal-like. So in this particular study, luminal B is hormone positive. HER2 may be positive or negative, but the Ki-67 is more than 14%. And so if it meets any of these criteria, where it's either HER2 positive or the Ki-67 is 14% or greater, then it's considered luminal B, which has a slightly worse prognosis than luminal A. HER2 enriched then is a cancer that's hormone receptor negative, but HER2 new is overexpressed or amplified. And then finally there's basal-like, which is hormone negative and HER2 negative as well. These different molecular subtypes are important because they are prognostic and they can actually be a little bit predictive of the response to therapy as well. So luminal A tends to have the best prognosis, and basal-like, which we call triple negative, typically has the worst prognosis. The other important thing to note is that basal-like and HER2-enriched cancers tend to have a higher response to neoadjuvant chemotherapy. So when we have a hormone-positive cancer that's treated with upfront chemotherapy, it's much less likely to have a good response compared to something that's either HER2-enriched or basal-like. Now, one thing to keep in mind is since this study was published, we understand basal-like tumors, or those triple-negative tumors, they're actually a very heterogeneous entity, and some of them have a more favorable prognosis. Some of them have less favorable genetic profiles. So as we learn more and more, we're learning that this isn't maybe the best way to classify, and there might be subclassifications within these types of cancer, but this will come up, and so it's important to be familiar with this system of molecular classification. So kind of tying it all together, so far we've talked about kind of the presentation, the workup, the imaging modalities. So typically these patients will present with something abnormal on a screening mammogram, which prompts a diagnostic mammogram, and then that often prompts a core needle biopsy if there is something abnormal there. And so when we get that initial core needle biopsy, what are we looking for on the pathology report? So number one, we talked about verifying that it's cancer and noting the morphology of the cancer. So if it's invasive ductal versus invasive lobular, or one of those other subtypes that we talked about. And then the other most important things to note on that initial biopsy from the core needle biopsy is the hormone status, the HER2 status, and the Ki-67, like we just talked about in those molecular subtypes. So estrogen and progesterone receptor status. Be sure to note the level or percentage of estrogen and progesterone. So if it's less than 1%, it's considered negative. If it's less than 10%, it's considered low positive. And anything higher than that is just considered positive. So keep in mind if it's a low positive or a true positive. And also keep in mind that sometimes it's expressed as a percentage, sometimes it's expressed as a level on a slightly different scale. So just whatever scale they're using on the pathology report, they should kind of verify that. But you want to make sure that it's a true positive versus a low positive versus maybe even a negative if it's less than 1%. The other thing to do is to keep in mind the HER2 new status. So there's two different ways, two different molecular techniques that we can use to verify the HER2 new status. So one of them is IHC, which is immunohistochemistry staining. And IHC detects the level of the protein. And we can basically get four different numbers from IHC. 0 and 1 plus are considered negative. 2 is considered equivocal, and 3 is considered positive. So IHC detects the level of the protein, and 0 and 1 are negative, 2 is equivocal, and 3 is positive. If we have an equivocal result, the next thing that you can do is FISH testing. So FISH will detect the exact number of copies that are on the gene, which is the HER2 new gene is located on chromosome 17. And the FISH will help to tell us if it's HER2 amplified or not amplified. So typically, we first obtain an IHC. So 0 and 1 is negative, 2 is equivocal, and 3 is positive. And if the IHC is equivocal, then we go ahead and get the FISH testing to detect the exact number of copies on the gene. So if it's HER2 positive, we use FISH to determine if it's HER2 amplified or not amplified. And then finally, the other thing that you can kind of glean from that original core needle biopsy path report is the proliferation index, the Ki-67, which is typically reported as a percentage from 0 to 100. And remember that less than 14% is considered low, which is luminal A. You might see some different cutoffs for this, like maybe 13.5 or 15%. They're all close enough. I just think 14% of the cutoff, and less than 14% is considered low Ki-67. Once the patient gets the core needle biopsy and once they get their the clinical staging, so depending on how big the tumor is, depending on whether or not there were any clinically suspicious lymph nodes, that may or may not prompt further imaging, like we talked about, like systemic imaging to rule out distant mets. So, every patient is different, and we'll kind of talk more later about the staging and the treatment paradigm depending on the stages. But at some point, the primary treatment for breast cancer is surgical excision. So at some point, either right after they get the core needle biopsy, or if they are a higher risk patient and we're thinking about giving them some upfront systemic therapy, at some point they're going to go for surgery. And it's really important to know what kind of surgery they get. So sometimes they might get a mastectomy, and sometimes they might get a lumpectomy or a breast conserving surgery. And all of that is a very nuanced decision. It depends on the patient, what their risk is, what they want, maybe even what their family history is. It also depends on how big the tumor is and whether or not the surgeon can feasibly perform a breast conserving surgery, or if they think the tumor is just too big and they would need to perform a mastectomy. But at some point, the takeaway is that the patient is going to require surgery, and it may or may not be preceded by upfront chemotherapy, and the different types of surgery really depend on many different risk factors. But when we look at the pathology report for the surgical specimen, say the patient just had a lumpectomy, okay, so breast conserving surgery, there's a few additional things that are really, really important for us to note, and I want to talk about them here. So the first thing that's super important is the gross features of the tumor, right? So make sure you're noting the tumor size, the focality, whether it was a unifocal tumor or a multifocal tumor, and where in the breast the tumor is located. So remember we talked about the o'clock position and measuring the distance from the areola. That's a great way of kind of keeping in mind where in the location is the tumor located, where in the breast is the tumor located. The next thing to keep in mind is something called the Nottingham grade. So Nottingham grade is a sum of scores. So a score of 1 to 3 is assigned for each of 3 different factors. These include tubular formation, nuclear pleomorphism, and mitosis. So tubular formation, nuclear pleomorphism, and mitosis. For each of these 3 factors, we assign a score, 1 to 3, depending on how aggressive it is. The sum of these 3 scores is called the Nottingham score. So that gives you a number from 1 to 9. And then the grades are kind of the different groups of scores. So grade 1 is a score of 3 to 5, grade 2 is a score of 6 or 7, and grade 3 is a score of 8 to 9. But basically, the higher the Nottingham grade, as it goes from 1, 2, and 3, the more aggressive these tumors are, because the more mitoses we see, the more nucleopleomorphism, the more tubular formation. So the Nottingham grade kind of gives us a sense of the grade of the cancer. So how aggressive is the cancer? Other things to keep in mind are LVSI and EIC. So what are these? Lymphovascular space invasion, or LVSI, is when the pathologist sees that there's actually cancer invading into the little blood vessels or the lymphatic channels that are located around the tumor. And that is a risk factor, because if we see that there's cancer invading into these channels that travel to the lymph nodes, that's an indicator that maybe this could be more at risk of spreading to regional lymph nodes. So LVSI is definitely a risk factor. The other risk factor that we typically think about is something called extensive intraductal component, or EIC. EIC is defined as having greater than 25% of a DCIS component. So sometimes you might get an invasive ductal carcinoma with a carcinoma in situ component. And if it's greater than 25%, it's often thought of as an additional risk factor. So these are just things to keep in mind in the pathology report. And then finally, you've noted what kind of surgery the patient had. It's really important to keep in mind what the resection status or the margin status of that tumor is. So what we think of as a sufficient margin status kind of depends on what kind of cancer it is. So if it's an invasive ductal carcinoma, no tumor on ink is considered to be a negative margin. However, if we're thinking about DCIS, a clear margin is really greater than 2 millimeters negative. So a clear margin for invasive cancer is just no tumor on ink, but a clear margin for DCIS is at least 2 millimeters of a negative margin. And so then when you think back to that extensive introductal component that we talked about, the reason it's so important, and if there's greater than 25% DCIS component, we consider it high risk because DCIS kind of requires a greater margin in order to be considered sufficiently clear. And so that's why that EIC that we talk about is a risk factor. So I always used to get very overwhelmed by these pathology reports when I was looking at breast cancer patients, and the disparities between the core needle biopsy report and then all this additional information to digest in the actual surgical specimen was really overwhelming. So basically everything on that surgical specimen pathology report is super important. And I've tried to kind of highlight these things that you should really be paying attention to. So gross features, the Nottingham grade, whether or not there's LVSI, an extensive introductal component, and of course the margin status. And the pathologist will kind of note the entire specimen that was removed, and they'll be able to mark out where those positive margins were. So if they were located posteriorly or medially or laterally, these are all things to keep in mind when you're kind of dissecting these pathology reports. So one thing that we did not talk about in the pathology report, which is also super important, is to note how the lymph nodes were assessed. And in future talks, we'll get into the data on axillary lymph node dissection versus sentinel lymph node biopsy. Most patients these days are just getting a sentinel lymph node biopsy, and we'll talk about kind of what that technique is and what it entails in the future. But it's really important to note how the lymph nodes were sampled, how many lymph nodes were sampled, and what they showed, because that obviously affects staging depending on how many lymph nodes are involved, and that'll help to tailor our adjuvant treatment after they get the surgery and lymph node sampling. So takeaway is keep in mind that the pathology report will also reflect what was done to the lymph nodes, and that's really important to note. The very last thing I want to talk about before we conclude this super long part 1 overview of breast cancer is something called the Oncotype DX 21 gene recurrence score. So there's different gene recurrence scores that have been developed based on different numbers of genes. And they basically, take a data set of patients and look at a bunch of genes, and based on the quantitative expression levels, they come up with a mathematic formula. In this case, the Oncotype formula includes 16 genes plus 5 reference genes, giving us that 21 gene recurrence score. And they kind of use this formula to optimize the prediction of distant relapse. And this gives us kind of the recurrence score. Oncotype is not the only one that's been developed. There are other genomic assays such as MammaPrint, which uses 70 genes. Blueprint uses next generation sequencing. So there's different scores, but Oncotype is a really common one. And it's a prognostic tool because it prognosticates the risk of recurrence. And it has also been validated as a predictive tool. So predictive means it predicts what kind of a response patient will have to a certain therapy. And the Oncotype score has been validated in the Taylor RX trial. So what was this trial, and what does the Oncotype score tell us? So the Taylor RX trial took patients with hormone-positive breast cancer who were node negative, and they randomized them to different therapies depending on what their Oncotype score was. So patients with an Oncotype score of 11 to 25 were randomized to either endocrine therapy alone or endocrine therapy plus chemotherapy. The patients that had an Oncotype score of greater than 25 always got both chemotherapy and endocrine therapy, and the patients that had a low Oncotype score of less than 11 always got just endocrine therapy alone. But it was these intermediate risk patients, the ones with a score of 11-25, that they didn't quite know what to do with. And so they randomized them to either get endocrine therapy alone or endocrine therapy plus chemotherapy. And what they found is that in these patients with an Oncotype score of 11 to 25, endocrine therapy alone was non-inferior to chemoendocrine therapy for invasive disease-free recurrence at 9 years. So in both of the groups at 9 years, the disease-free recurrence was about 83 to 84%. And so from this trial, kind of the treatment paradigm that emerged is that for patients greater than or equal to 50 years old, if their score is greater than 25, so if they have an oncotype score of 26 or above, these are the only patients that we add chemotherapy for, in addition to the endocrine therapy for these hormone-positive, clinically node-negative patients. These patients are also HER2 negative, which is important. For the patients that are less than 50 years old, however, based on a subset analysis, they found that if patients were younger, less than 50, and they had a score of 16 to 25, then they benefited from chemo as well. So for patients less than 50 years old, if their score is 16 to 25, we consider adding chemotherapy based on that subset analysis. However, for these patients that are 50 years old or greater and their score is 26 or above, these are the only patients that are getting chemotherapy in addition to endocrine therapy. So the only reason I wanted to mention this is because you will see that a lot of medical oncologists, when they see patients that have hormone positive, HER2 negative, clinically node negative, and pathologically node negative after surgery, breast cancer, they'll often send an oncotype score. And the reason that we get that oncotype score is it helps us to decide whether or not these patients need adjuvant chemotherapy. And sometimes when you see these consults in your clinic, you might have a discussion with them about adjuvant radiation. And oftentimes our decision kind of depends on whether or not they need the chemotherapy and when we can start the radiation. So I'm not saying that our decision to give radiation depends on it, but our timing of the radiation and when we plan to deliver the radiation sometimes will depend on getting that oncotype score. So key takeaway from the Taylor RX trial, this was a trial in hormone positive, HER2 negative, lymph node negative patients. And the takeaway is that for patients greater than 50, if their score is 26 or above, we add chemotherapy to endocrine therapy. And if patients are younger than 50 and they have a score of 16 to 25 based on a subset analysis, again, we add chemotherapy to the endocrine therapy. So I was very ambitious when I said that we would get through the presentation workup, imaging, pathology, and staging. We're already over 45 minutes and I haven't yet had a chance to talk about breast cancer staging. I think that's okay. I think just in the interest of keeping this talk under at least an hour, what I'll do is divide it into two parts here. In the next part of the overview, we will go over the staging and treatment overview. Hopefully that will not take as long, and we'll leave it here. I think we've covered a lot of very important information about how we work up and kind of go through the steps of assessing patients that have breast cancer. And we've talked about a lot of important details regarding imaging and pathology. So we'll leave it here. And in part 2, we will come back for a wrap up on this particular slide deck with a discussion of staging and treatment paradigm. Thank you.